Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our brilliant senior residents, Abigail Olinde. Welcome to the podcast, Abby.
Thanks. It's great to be here.
For this episode, we're going to discuss an electrolyte abnormality that we often encounter in the emergency department, but seldom does it get the spotlight for a topic of review. Hyponatremia usually steals the show, but not today. The time has come for us to go through the nuts and bolts of hypernatremia evaluation and treatment. So, Abby, start us off by talking about what it is and, in general, how it happens.
I'm so glad we're talking about this topic because hyponatremia really does get most of the attention in the emergency department. But it's important to think about hypernatremia too. So what is hypernatremia? High sodium, obviously, but it is defined as a serum sodium over 145 milliequivalents per liter. We'll talk more about chronicity later, but with hypernatremia, almost all patients will fall into this chronic category, which is greater than 48 hours, even if they just started developing symptoms. And these symptoms are not very specific at all. A patient can have anything from nausea, vomiting, to delirium, to seizure, to coma, and even death. Now, the reason that hypernatremia is usually rare is because when your serum sodium gets high, your thirst response should kick in and bring that sodium back into a normal range. So anyone like you or I shouldn't get hypernatremic because our bodies are great sodium regulators. But what happens when your thirst response doesn't kick in or you don't have access to water? Then your body can't keep up and you'll lose water faster than you can get it in your system. The best way to think about this is that water loss exceeds water intake. So what's causing the water loss? Everything from your skin, so sweating from fever, exercise, high temperatures, your GI system, vomiting, diarrhea, and your kidneys, diabetes insipidus or osmotic diuresis. Some of that was pretty straightforward, but let's break down the renal losses. Diabetes insipidus can be divided into two categories, central or nephrogenic. Central is a decreased release in antidiuretic hormone, which can be caused by things like intracranial hemorrhage, brain tumor, or surgery, and herniation. Nephrogenic is a decreased renal response to antidiuretic hormone, which can be caused by medications like lithium or amphotericin, and even chronic renal insufficiency. I also brought up osmotic diuresis, which is just when something like glucose, mannitol, or urea increases the osmolality of urine and therefore increases the release of sodium. Now, just like we've always been taught, you think about horses before zebras. Hypernatremia caused by water loss should always be on the top of your differential. But another cause could be things that increase sodium itself, like sodium poisoning. Things like multiple amps of sodium bicarb, hypertonic saline, and even increased sodium ingestion, like that one patient who drank a quart of soy sauce and everyone is still talking about it.
Okay, so that's pretty easy to remember, 145, and there are a lot of ways to get to this point, to become hypernatremic. Now, talk to us about which patients are going to be most at risk for developing significant hypernatremia.
Hypernatremia should stimulate thirst, so the patients who develop significant hypernatremia are having inadequate free water intake, and you should ask yourself, what is the reason for this? Do they have a brain abnormality causing impaired thirst response, or are they unable to access water on their own like many altered or ventilated patients?
Great, Abby. And once again, touching on a common theme that runs through a lot of the topics covered in this podcast, that timing is almost everything. And now we have a patient in whom we are concerned that there might be an electrolyte abnormality. And this is usually the case, right? We usually get our chemistry back and find hypernatremia instead of ordering labs for the sake of determining if hypernatremia is present and, if so, to what degree. But beyond the chemistry, what are the other important components of your workup once we are dealing with a patient with an elevated sodium?
The most important tool in a patient with hypernatremia is the history and physical. Many times the diagnosis can be obtained by this alone, but tests can help reinforce our diagnosis and guide our treatment. Always think about if hypernatremia makes sense in your patient. Lab errors are possible, so if the story doesn't make sense, repeat the chemistry. An easy way to be tricked by a BMP is seeing a normal sodium and moving on. Remember that sodium is affected by glucose, so you should always be checking that number as well and correcting. If the sodium is 143 but the glucose is over 800, you may be lulled into a false sense of security until you correct. If the sodium is still high or the glucose is within normal range, you'll want to collect urine studies, including urine osmolality and urine sodium. With these labs, we're trying to rule out certain causes of hypernatremia. So if the urine osmolality is less than 300, we should be thinking about diabetes insipidus. And if it's greater than 600, we should think about extrarenal water loss. Unfortunately, there is a gray zone between 300 and 600 where this test isn't as helpful. Now with urine sodium, if the test is less than 20, we're thinking about GI water loss, whereas greater than 100, we're thinking about salt toxicity.
Okay, so we know our patient is hypernatremic. To what degree and what type of hypernatremia and chronicity? Tell us how we can go forward with treatment, and what are you considering when you start to correct the sodium derangement? Initially with a broad overview, and then let's get down to the numbers and formulae.
So similar to hyponatremia, we can have acute or chronic, with chronic being greater than 48 hours. This is because sodium does not easily cross the cell membrane, so it takes about 48 hours for your brain tissue to adapt. So although unlikely, if your patient is acutely hypernatremic, which is less than 48 hours, you don't need to worry about overcorrection, and you want to decrease the sodium to normal as quickly as possible. But if your patient falls under the chronic category, you'll need to be a little bit more cautious. And again, similar to hyponatremia, we want to consider our target rate of correction and keep that in mind. The risk of overcorrection with hyponatremia is osmotic demyelination syndrome, whereas the risk of overcorrecting with hypernatremia is cerebral edema. You can remember the phrase high to low, brain will blow for hypernatremia and cerebral edema, and low to high, pons will die for hyponatremia and ODS. Not officially the medical term, but easy to remember. Hypernatremia is unlike many other topics in medicine. While most of the medical decision-making is derived from research done in adult patients, the guidelines for correcting hypernatremia is from the pediatric population. Based off this data, the safe rate of correction is 10 to 12 milliequivalents per liter per day, or 0.5 milliequivalents per liter per hour. Given that there are also possible risks for correcting too slowly, if we slightly exceed our goal, we tend not to raise the sodium back up. This is very different from hyponatremia, where you need to follow the guidelines very closely. So what's the first step to treatment? Calculating the free water deficit is the first and most important step to take. You can always look this equation up online, but essentially it's your current sodium over the goal sodium, which is usually 140, that number subtracted by 1, and then multiplied by the total body weight, which is usually 50 to 60% of lean body mass, depending on age and gender. Next, you'll need to find the route of administration. If the patient is able to take water enterally, you should give it orally by NG tube or by G tube. If that's not possible, or you need additional help due to a high free water deficit, that's where D5W comes in handy. Remember that you should check the glucose frequently when using any dextrose-containing fluid. A question that always comes up is, what if the patient is hypovolemic? If there is concern for hypovolemia or the patient is unstable, D5W will not help with the volume deficit. Stabilize the patient with isotonic fluid, such as normal saline or lactated Ringer, and manage the sodium separately. The only outliers in treatment come with the outliers in causes. If you have central diabetes insipidus, you may want to treat with desmopressin. And if you have a life-threatening acute case of salt ingestion, you may need to use hemodialysis as an alternative or supplement to D5W.
And this is a very important point that you made, that we should resuscitate before we correct. Now, let's go on to the next steps. When are we sticking these patients again for repeat labs, any other monitoring? And one of the harder questions, whom do we admit and whom do we discharge?
As you're treating a patient for hypernatremia, they may continue to have water loss. Monitoring the urine output and reassessing the free water deficit to determine additional need for free water is always important. In addition, sodium should be checked every 4 to 6 hours to monitor for under or overcorrection. Now, the disposition decision is a bit difficult, and many times it depends on the hospital where you work. Patients with symptomatic hypernatremia should be admitted for treatment, and those with severe neurologic symptoms or sodium greater than 160 milliequivalents per liter will likely require admission to the ICU. Patients who are hemodynamically stable and asymptomatic with mild hypernatremia from a benign cause may be discharged with close follow-up.
Okay, and I'm glad that we're shifting the attention to hypernatremia and reviewed this essential topic that we encounter on almost every shift. Now, let's go over some take-home points. Hypernatremia is defined as a sodium level of over 145 milliequivalents per liter, with a broad range of symptoms that go from nausea all the way to coma. It's mainly caused by water loss exceeding intake due to sweating, vomiting, diarrhea, renal losses, or excessive sodium intake. And the list of causes is a long one that would be too bulky for the podcast. But we'll have a table in our show notes for those who want to take a deeper dive. We have to be judicious with our correction, and doing so quickly can lead to cerebral edema. Generally, the safe rate will be 0.5 milliequivalents per milliliter per hour. Initially, treatment involves calculating the free water deficit and choosing the appropriate administration route, and larger free water deficits might need D5W. And don't worry, we'll have the formulae in the show notes as well for your reference. Lastly, when you're correcting, try to monitor the sodium every 4 to 6 hours, and some patients might require the ICU if they're symptomatic or severely hypernatremic. And the decision to admit or discharge is going to be a complex one that considers numerous factors, including symptoms, degree of sodium derangement, medical literacy, and access to follow-up. Okay, that'll do it for this episode. Again, Abby, thanks for joining us.
Thanks for having me.